Thank you so much for asking me to give a talk on hemostasis for ENT. I have looked at your list and put together what I hope will be helpful to you. So I'll try and do this in 15 minutes. I'm going to go through the objectives that you set for me: history taking, interpreting blood results, common causes of coagulopathy perioperatively, know when to use platelets, DDAVP, or you need to reverse anticoagulants. A quick look at TEG and ROTEM. I don't use these, but I've covered them in one of the slides, and massive transfusion protocols, and then cancer-related bleeding or clotting risks. So hemostasis is a fine balance between coagulation. We don't want to bleed to death, but you also need natural anticoagulation. You don't want to clot to death either. And it depends on two major things. One is platelets for the primary hemostasis, and then you've got the clotting cascade, which I'll take you through now. Just for your reference, this is what platelets look like and what they contain. In the resting state, i.e. non-activated, they're kind of spherical. And then when they are activated, they send out pseudopodia, which then bind to von Willebrand factor on the endothelium, and then they clump together, and that's your primary hemostatic plug. And then the coagulation factors come in on top of that. So let's have a quick look at the coagulation cascade, which is pretty tedious, I know, but I have to go through these for you. There is a pathway called the extrinsic pathway, which is activated by trauma. We have an intrinsic pathway, which is within the blood vessels. That's like damaged vessel surfaces, for example. And they both meet with the final common pathway here, which I'm showing from 10 to 10A, then prothrombin to thrombin, and then fibrinogen is converted to fibrin, the clot. So that's putting all these things together: intrinsic, extrinsic, common final pathway here. Now, this is where these arise: damaged surface through contact with abnormal surfaces, which is more of a laboratory ex vivo thing. Exposed collagen, artificial surfaces, dialysis, bypass, ECMO, and that amplifies the clot formation. The trauma side is more what you're involved with in terms of ENT. You've got surgery, you've got trauma, epistaxis, tonsillectomy, dental extraction, and tissue factor 7 exposure. So there's a whole pathway together. Now notice I've added some other things on here. I've added protein C, protein S, and antithrombin. These are the natural anticoagulants. I said it was a balance between coagulation and anticoagulation. We need anticoagulants in the mix as well. Otherwise you'll form a blood clot, but you won't stop clotting. You have to switch it off, and that's how we switch it off. The test for these, for the intrinsic pathway, is the activated partial thromboplastin time on the left, APTT, and for the extrinsic pathway, you've got the prothrombin time, the PT. Finally, in the cascade, we have the anticoagulants that we give our patients. Warfarin, for example, bottom left, that's the vitamin K dependent clotting factors 2, 7, 9, and 10. You can see them there with the circles. And then we have the direct oral anticoagulants, the newer drugs. You've got apixaban, rivaroxaban. They inhibit factor 10A. They're anti-10A drugs. And then you've got dabigatran, which is a direct thrombin inhibitor. So those are the pharmacological anticoagulants as opposed to the natural anticoagulants. In terms of reversing anticoagulants, which you may have to do, dabigatran, you use something called idarucizumab, which is a monoclonal antibody. It binds to dabigatran, inactivates it. Apixaban and rivaroxaban, we reverse with something called andexanet. It's a decoy 10A. And then for non-specific reversal, you've got the 4-factor prothrombin complex concentrate, which contains factors 2, 7, 9, and 10, along with protein C and S. So 90 seconds of hemostasis. Primary hemostasis, as I said, is the platelet plug. Secondary hemostasis is when the coagulation cascade comes in on top. And then you've got fibrinolysis, where you break down the clot. So in terms of the history taking, ask the patients about where they're bleeding from. Is it their gums, their nose? What brings on the bleeding? What are the provoking factors? Have they had surgery in the past? What's their post-op history like? Is there any family history of bleeding disorders? What medication are they on? Aspirin, non-steroidals, etc. Are they on a DOAC or maybe warfarin? You need to know that. What supplements do they take? Some interfere with platelet function, as you can see here. And what comorbid disorders do they have, which might, again, lead to coagulopathy? Interpreting the tests, Prothrombin, or the international normalized ratio, that's derived from the prothrombin time. That measures the extrinsic pathway, and you can see it's abnormal with warfarin, liver disease, etc. The APTT, we're looking at the intrinsic system, which is the one I had on the left, which measures factors 12, 11, 9, and 8. Goes up with haemophilia A, haemophilia B, and heparin. Again, for ENT, if you've got an isolated long APTT, check factor 8, factor 9, and von Willebrand factor. Fibrinogen is right at the bottom of the cascade. It's low in DIC. Your target should be 1.5 for surgery. Platelets, this is the platelet count. It's not measuring platelet function, just a number. Low in thrombocytopenia, like ITP, for example. Aim for 50 or more for ENT surgery. More than 80 if you're doing airway cases. Thrombin time, I'm not going to go into that here. Perioperative coagulopathy, dilutional. If you give tons of saline, you will dilute out the clotting factors. Try and switch to something like balanced crystalloid or colloid, and consider early fresh frozen plasma. Hypothermia causes coagulopathy. Acidosis causes coagulopathy. DIC, as you know, of course, disseminated intravascular coagulation causes coagulopathy. Drug-induced, DOACs, heparin, warfarin, antiplatelet agents, liver disease, renal disease. What about platelet thresholds? Right, platelet transfusion thresholds. If the platelets are under 50, you'll want to give some platelets possibly before elective ENT surgery. If you're going to do something airways or intracranial, get the platelets up to around 100. One therapeutic dose of platelets will bring the count up by 20 or 30. Not helpful in ITP, because the ITP, they have antibodies that destroy the platelets. DDABP, this releases von Willebrand factor and factor 8 from the endothelium. I've given the dose there. Use it in VWD type 1, mild haemophilia A, and some platelet function defects, and uremic bleeding. Avoid it in certain types of von Willebrand disease, as I've got on the slide there. Anticoagulant reversal I did earlier, so I won't go through that again. Thromboelastogram. This is something I looked at in my hospital. We don't actually use it. It basically looks at whole blood, and you get a curve in terms of the whole blood clotting, and from the shape of the curve and the height of the wave, you can tell how good or not good the coagulation system is in a patient, and it identifies what you need to give in terms of blood products, which I've listed there. Massive transfusion protocol. If you give someone tons of red cells, like more than 10 units of red cells over one day, 24 hours, or more than 4 units in 1 hour, you should activate your massive transfusion protocol. Give a ratio of 1 to 1 to 1, red cells, FFP, and platelets. Okay? Give cryoprecipitate, which is mainly fibrinogen, if your fibrinogen is less than 1.5. Give tranexamic acid, 1 gram IV, within 3 hours of major hemorrhage. Don't forget about the calcium. You may need calcium replacement as well, because the citrate in the blood products will chelate, i.e. binds to the calcium. Cancer-related bleeding and clotting risks. Well, the bleeding risks in cancer, you've got thrombocytopenia, low platelets because of marrow infiltration by, say, solid tumors or leukemias or lymphomas or prostate cancer or whatever. Then you've also got DIC in cancer, especially acute myeloid leukemia, the M3 variant, commonly associated with disseminated intravascular coagulation. Mucin-secreting adenocarcinoma, also highly associated with DIC. You've got acquired factor inhibitors, which is paraneoplastic, like acquired factor 8 inhibitor. The tumor vascularity, the tumors are highly vascular, especially head and neck. Be very careful. People who've had prior radiotherapy, you've got fragile mucosa and poor wound healing. Anti-angiogenics gives you impaired hemostasis, and thrombocytopenia plus aspirin is a bad combination because you've got low platelets and an antiplatelet agent. This causes epistaxis. Clotting risks. Malignancy is predisposes to thrombosis, so-called Trousseau syndrome. Head neck cancer, especially the VTE incidence is 6 to 10%, which is quite high. Chemotherapy, certain chemotherapy drugs like cisplatin, L-asparaginase can increase the risk of venous thromboembolism. Peripherally inserted catheters and central lines, again, can predispose to VTE of the upper limbs. Immobility post-treatment, or for whatever reason, post major head and neck resection, if they're immobile in bed, that predisposes to VTE. give thromboprophylaxis in active cancer, low molecular weight heparin, and if you diagnose venous thromboembolism during active cancer, give extended anticoagulation with a DOAC or low molecular weight heparin. Okay, here's a quick decision aid for ENT bleeding scenarios. Post-tonsillectomy bleed with a patient who is on aspirin. Stop the aspirin, but it does last for 7 days though. It's got a long half-life. Give them DDAVP if there's no contraindication. Give them platelets if the platelet count is less than 50. Contact haematology and contact your senior and if the bleeding is ongoing. But it's worth talking to haematology anyway. In an elective patient with an APTT prolonged at 68 seconds, the prothrombin time is normal. So the intrinsic pathway is affected, the extrinsic seems to be okay. They're not on anticoagulants. Do a mixing study. Ask the lab for a mixing study, adding normal plasma. If it corrects, it means there's factor deficiency. If it doesn't correct, it means there's an inhibitor. Again, discuss with hematology. Elective patient, von Willebrand disease, known, planning for microlaryngoscopy. Pre-op DDAVP, if they're type 1 VWD or von Willebrand factor concentrate. Manage this alongside the hematologist, contact hematology and get them involved. Tranexamic acid mouthwashes post-op. Elective surgery, pre-op, the INR is prolonged, 2.8, they're on warfarin, so that's going to affect the INR. This is for elective thyroidectomy. Withhold the warfarin for 5 days. Check the INR on the day of surgery. If it's urgent, you can give vitamin K and the 4-factor prothrombin complex concentrate. That will correct this really quickly. Here's another urgent one. Head and neck cancer, unexpected intraoperative bleed. Activate the major transfusion protocol. If major, you'll decide how major the bleed is. Check the platelet count. Are the platelets low? Check the fibrinogen. Is it okay? Check the prothrombin time in the APTT. Consider doing a DIC screen. Call hematology. You'll need hematology for that one. And finally, the patient on dabigatran, urgent neck exploration. They're on a direct oral anticoagulant. They are anticoagulated. Use the drug there, that Praxbind, 5 grams IV, gives full reversal in 5 minutes. Confirm the last dose time of their DOAC and also check their renal function as well. So the key messages for ENT and hematology, the bleeding history is really important. You do want to know what they've had done in the past and whether they bled or not. Ask about the pattern, the provocation, the drugs, the family history, of course, as well. DDAVP, desmopressin, is safe, it's fast, and it's underused in ear, nose, and throat surgery. It's ideal for von Willebrand type 1 and uremic bleeding. The TEG and the ROTEM guides goal-directed therapy. If you've got that in your hospital, then you can use the TEG and the ROTEM, treat the specific defect. A normal PT and APTT does not exclude von Willebrand disease or platelet function defects. They're quite separate to the PT and APTT. For DOAC reversal, idarucizumab for dabigatran and andexanet, or 4-factor prothrombin complex concentrate for the 10A inhibitors. Cancer patients bleed and clot. They have the double whammy of bleeding and thrombosis. Both risks need active management around any ENT procedure. And that was my final slide, so thank you so much.